So I'm going to kick it off by introducing one of the co-chairs of the group, Dr. Megan Ranney. Some of you here maybe knew of Dr. Ranney well before all the recent news about gun control following the Parkland shooting. I did not. I read about Dr. Ranney based on an interview she did with the Providence Journal about a month or so ago. And as soon as I read that, I said, well, I have to meet her, and I need to find out who she is. And as soon as I did that, and I learned about Dr. Ranney's experience, her research, her writing, and her advocacy, I became convinced that she was going to be the right person to chair this group. Dr. Ranney, in addition to being a really nationally recognized researcher on gun violence prevention, is really on the front lines of this issue as an emergency room doctor. So she doesn't just write about gunshot wounds, she treats gunshot wounds. And I believe that her perspective is going to be invaluable. So we're going to kick off this meeting with an overview of the costs of gun violence on our community. Dr. Ranney.
Thank you. Thank you. Is there a clicker thing or no? All right.
Just tell us one.
Should I stand? I can stand here. This works. Can you guys still see? All right. So it's truly an honor, Dee and Governor Raimondo. Thank you for the opportunity to co-chair this. I'm going to give a little bit of an overview today around kind of the epidemiology of firearm injury, which for many of you sounds like something you should go to sleep in a college class. But to kind of get us all on the same page about what firearm injury is and what we can do. You can go forwards. Conflicts of interest. As an academic physician, I always disclose my conflicts of interest. I do have NIH funding. I chair national work groups, and I'm in a voluntary position as a chief research officer for a philanthropy that funds firearm injury research. And I acknowledge Dr. Betts and Dr. Wintemute, with whom I've given parts of this talk before. So I'm going to start this talk with a story, and I'm going to kind of say at the outset that this story may be a little upsetting, and so if it is, and as a good Brown professor, if it is, if it upsets anyone, certainly I'm happy to talk to people afterwards. But one of the reasons why I work on gun violence, so I've done violence prevention work for over a decade. And in 2000, I've done kind of violence and sexual assault, domestic violence work for a long time. When I was a brand new emergency physician attending at Rhode Island Hospital in one of my early shifts as an attending, I was in the trauma rooms, and a patient was brought in by EMS. And we got this panicked EMS call, which for those of you that work in pre-hospital, our EMS colleagues are never panicked. They came in, lights and sirens, and it was a young man who had shot himself in the head with his father's gun. We did everything that we could to save him, but the injury was not survivable. And looking at that young man and at his father changed my perspective on guns and gun violence. Up until that point, I had treated gun violence as something that was somewhat abstract, largely an issue of community violence. I'd done a lot of work with the Institute at that point. And taking care of that young man was the first time that I thought about gun violence as being an issue of suicide as well as homicide. And it was the first time that I started to wonder, why have we not done more to prevent this? Because his father could have potentially done something to help prevent his own son from taking his life, and not to put that death on the father's head at all. But it made me start to question, what is it that we can do as a society to help people like him to survive? You can go, and so we kind of raised this question of, can we and should we reduce gun suicide, gun homicide? Next slide. So an important thing to understand is firearm ownership varies tremendously by state. These are 2013 stats. These are the most accurate that we have. It ranges from Rhode Island being among the lowest rates of gun ownership to states such as Alaska and the kind of Midwest, or kind of upper, the Mountain West, that have greater than 40% gun ownership. Next. But regardless of where we live, gun deaths affect us, right? So firearm death rates across the country are approximately 10 per 100,000. And you see, again, Rhode Island is relatively low, but they're still present here. Next slide. In 2016, over 36,000 people died of gun injuries across the United States, and another 85,000 were injured. I strongly believe that we can and should help reduce firearm injuries and death. I work in the Injury Prevention Center at Rhode Island Hospital. We have an entire science of injury prevention that we have applied to everything from car crashes to pool drownings. The one thing we have not applied it to is guns. And we can do gun violence prevention using evidence-based methods that are acceptable to our community. And as Governor Raimondo mentioned, this is about listening to all members of our community and really representing their voices and using the best science to do the best that we can for our state to reduce deaths and injuries. And I believe that this task force can be part of the solution. So next slide. I'm going to do a quick overview of numbers, framework for action, and then some ideas about what we can do. And then Adi and Jim are going to talk more about some specifics around the state laws. So numbers, the epidemiology of firearm death. So who dies from firearms in the United States? Next slide. Along the bottom, you'll see age groups, so going from age 0 up through age 85, and here is the number of deaths. So you see that these are boys who die, next slide, and these are girls. So most gun deaths are male, right? There's a huge spike in gun deaths in the 15 to 19 age group. So 2016, 85% of firearm deaths were male. Next slide. Next. When you look at the distribution of males that die, though, if you look at non-Hispanic whites, next slide, versus non-Hispanic blacks, you'll see that there's a huge spike in deaths, gun violence deaths for minority men at the prime of their life, right, in that 15 to 24 age group. For white men, there's a huge spike in gun deaths in the middle-age age group. And the reason why, does anyone know? I'll get on my professor hat here, right? What's the difference? Suicides, right? So suicide versus homicide. Next slide. And if you actually look at the overall number of deaths, 62% of gun deaths nationally are non-Hispanic whites. Next slide. Why are they dying? So we talk a lot about mass shootings, and mass shootings are certainly what has galvanized this task force, appropriately so. They create fear, they're a form of terrorism. But when you look at the number of deaths in 2016, next slide, approximately less than 2% are accidental, so like a little kid grabbing their parent's gun and shooting themselves or a family member. Next slide. Less than 1% of gun deaths nationally are mass shootings. Next. Approximately 40% are from homicide and legal intervention. I'll say that includes domestic violence homicide because it's really difficult to separate out the numbers. It's important to talk about domestic violence somewhat separately from other homicide deaths. Next slide. And 60% of deaths, gun deaths nationally, are suicide. Next slide. But deaths are only part of it, right? This is a great slide that one of my friends made after Parkland that shows here's Parkland, right? But here's the United States up through the 18th of February. You can see the number of cumulative deaths versus injuries for kids nationwide in just those first 45 days of the 2018. Go ahead. So here in Rhode Island, why do we die? So obviously our numbers are smaller. We're a smaller state. But in 2016 alone, we had approximately 50 deaths. And our numbers are similar to the national ones. So again, very few accidentals. Thank God no mass shootings. May it please stay that way. As a parent of 2 kids who are in elementary school, every day that I send them to school, I think about it. But 20% are homicide, and about 80% of gun deaths last year in this state were suicide. So I think it's important for us to know what we're talking about when we're talking about preventing gun violence in this state. Next slide. It is important, though, so I talk about deaths, right? And here again, you see self-harm or suicide as most deaths, but assault is most injuries. And so in talking about suicide, I don't mean to downplay the importance of community violence. It has a huge impact on not only the people who are hurt, but also their parents, their loved ones, their larger community. It creates a culture of fear, right? And it's something that I don't mean to kind of diminish or not talk about. Next slide. So what can we do? There's a framework for action. Next slide. In evidence-based public health, right, we do a few things. The first step is surveillance. What's the scope of the problem? And that's what I just went through. How many people are dying? What are they dying of? What types of injuries are there? Next. Then we talk about what are the risk and protective factors. So why are people getting hurt? Who's getting hurt? Who's at risk for getting hurt in community violence? Who's at risk of getting hurt in suicide? How can we identify those people earlier? What mechanisms can we put in place to keep them safe? Next. Then we develop interventions, which is what this working group is going to do. And next. And then we evaluate it. We see, is there evidence? Does it work? And so types of interventions can include education. And education here could be things like educating gun shop owners about how to identify someone who's at high risk of suicide before selling a gun. It could be enforcement, stuff like Adi mentioned and the governor around closing loopholes and making sure that we enforce current laws. It could be engineering. So the example that I always give around engineering is that in this state, we're required to put a fence around our pool, right? I used to have a house with a pool. I was required to have a pool on all 4 sides, whether or not I had kids, right? And so that's an engineering thing that helps prevent pool drownings. And there are likely similar things we can do for guns. Next. And then once we figure out what we want to do, we implement it, and again, we see, does it make a difference? Now, why do I think this will work? Next. So this slide shows why I think it will work. Death rates in the US. Next slide. So this is car crash deaths. So despite the fact that we have more cars on the road than ever before, the number of deaths per 100,000 people in the US has dropped. So this is the death rate going up and down, and this is the going across. So the reasons why this has dropped is that combination of education, engineering, and enforcement. Next. This is HIV/AIDS. There were no deaths from HIV/AIDS, right? Then we had this huge spike. Then we did a lot of research and put a lot of stuff in place. It was not one solution, right? It was a lot of solutions, and we've decreased the death rate from HIV/AIDS. Next. But guns, our death rate from guns has stayed virtually the same since 1950 as a country. Next. And in fact, the death rate has increased recently with suicide and homicide going up. Next slide. Guns are the only kind of injury where the death rate is going up. If I take care of someone in my ER who is a pedestrian struck, a stabbing, a blunt force assault, kicked or punched, I can almost always save them, and my chance of saving them has increased. The chance of saving someone who comes in with a gunshot wound has decreased over the past 2 decades. Not because I'm not doing a good job, but because the types of shootings and the types of guns that are out there have changed. Next slide. Next slide. And the reason, one of the reasons why, of course, is that we have no research, but another reason why is that we haven't had necessarily the political will and the community organization to put these multimodal interventions into place. Next slide. You can go through. So I'm going to do a couple more slides and then I'll hand it over to Adi for the sake of time. Next slide. Next. So who needs prevention? Next slide. Oh, this is an older. I apologize. This is an older version. Next slide. It didn't come through right. Sorry. So when I talk about kind of who's at risk, the pictures didn't come through, but there's a few important populations to talk about. So one is people who are suicidal. Another is people who are at risk who disclose domestic violence. And then another is people who have been in a fight before. And then on top of that, we know that kids, people with Alzheimer's or cognitive decline, and people that use alcohol and substances are at higher risk of death and injury. And those people own guns. So national surveys show that about 1/3 of kids who are suicidal own guns. About 1/3 of battered women have access to a gun. And many of the deaths involve alcohol, right? So about 30% of gun deaths, people are acutely intoxicated. One note is that people who, so one thing that I often hear in the medical profession is people say, well, why even talk about suicide because you can't prevent it? But it's really important to know and to kind of frame us all that only about 10% of people with suicidal thoughts and actions actually die, right? But 90% of people who use gun for a suicide attempt die. And the moments between when someone thinks about hurting themselves and makes an effort are seconds. And so if we can decrease access to lethal means, we may save lives. So I'm going to go through here just for a little bit. There are a lot of safe storage options that we can use. But as a community, so we have education, enforcement, and engineering. I'm going to talk really quickly about some examples from other states, and then I'm going to hand it over to Adi. So one thing that some states have done is created suicide prevention partnerships with gun owner groups. So this is a colleague of mine works in Colorado, another friend works in New Hampshire on the Firearm Safety Coalition. They've gone and talked to gun shop owners and worked out in ways that are acceptable to everyone across the community, ways to decrease rates of suicide with a gun. Another example is hospital-based violence intervention programs. Here in Rhode Island, we're lucky to have ISPN, and I know PJ is on the task force, but creating kind of community programs that help to intervene and stop the cycle of assault and homicide or have some evidence nationally. Next slide. Oh, that didn't come through quite. Try again. Okay, so the next thing is this is a collaboration that I had with the Massachusetts Attorney General's office, where we worked to kind of create answers that physicians have around how they can help save patients. So as a doctor, I see patients every day who are suicidal or at risk. What is it that I can do to help them, right? And so we can work to create guidelines for physicians. And of course we can do research, and I know that many of the people, including Eric and Sean on this task force, are folks that are working with me as part of a multi-state consortium under Governor Raimondo's order to try to do research to look at what is the evidence that we have to put into place. So with that, I'm actually going to not go through these scenarios for the sake of time. I do have a series of resources, but that I hope is like a nice little overview of what we're facing here in Rhode Island, and also some ways that folks nationally think about the prevention strategies that we could potentially put into place. With that, I will turn it over to Adi for the legal part.